Good evening, and thank you for joining this Facebook Live event, the COVID-19 Vaccine Fact versus Fiction. This event is hosted by Simulation in Motion Nebraska, which is part of the IXL program at the University of Nebraska Medical Center. This presentation is originating from the Clarkson Regional Health Services Holographic Theater at the Davis Global Center on UNMC's main campus. My name is Doug Decker, Program Manager for Simulation in Motion Nebraska, and I'll be your host and moderator tonight. Sim Nebraska would like to welcome the emergency care providers who are serving on the front lines of COVID-19 crisis to this program. All of us here at SimNE thank you for your service and greatly appreciate your dedication and sacrifice. As in past events, you may submit questions online in the comments section of this event at any time during the panel discussion. I would now like to introduce our panelists. Our first panelist is Dr. Mark Rupp. Dr. Rupp is a professor and chief of the Division of Infectious Diseases in the Department of Internal Medicine at the University of Nebraska Medical Center. He is the medical director of the Nebraska Medical Center Department of Infection Control and Epidemiology. Additionally, Dr. Rupp is a diplomate, American Board of Internal Medicine in the subspecialty area of infectious diseases. He is a fellow of the American College of Physicians, the Infectious Disease Society of America, and the Society for Hospital Epidemiology of America, or SHAE. He is also past president of SHAE. Dr. Rupp has served as a consultant for the U.S. Food and Drug Administration, the Centers for Disease Control and Prevention, National Institutes of Health, and the Veterans Administration. He has recently served as the Chief of Staff of Nebraska Medicine. Dr. Rupp has published over 450 articles, chapters, and abstracts. He frequently presents papers at national and international meetings, serves as a guest lecturer, as an active teacher and researcher. Dr. Rupp's research interests are in the areas of healthcare-associated infections and antimicrobial stewardship. Our second panelist is Dr. Eric Ernest. Dr. Ernest is the Director of Pre-Hospital and Emergency Medical Services and Assistant Professor at the University of Nebraska Medical Center and Director of the UNMC EMS Fellowship Program. He is the State of Nebraska EMS Medical Director. He is also the medical director for several agencies, including the fire departments in Bellevue, Weeping Water, Elmwood, Nahaka, Greenwood, Meade, and for the Sarpy County Dispatch Center and the Cass County Emergency Management Agency. Dr. Ernest serves as the Assistant Medical Director of the Omaha Fire Department and Creighton EMS Education. He also works as an ER physician in Nebraska Medicine and spent 3 years working as a paramedic prior to attending medical school. As the program is turned over to Dr. Rupp, I would like to remind you to enter your questions in the comments section of this event at any time during the presentation, and the only official responses to questions in the comments section will come from a notation that has Sim Nebraska on it. Dr. Rupp.
Doug, thank you for inviting me to be here this evening. It's really very much a privilege for me, and I'm thrilled to be sharing the podium this evening with Dr. Ernest. I think as a way of introduction, it's probably useful for us to just take a look at the tally sheet right now and examine where we're at in the midst of this pandemic that's really been unprecedented in the United States and in the world for the last 100 years. There's just nobody alive today that can remember back when we had a time similar to this. Here in the United States, we have up to 21.5 million cases of COVID-19 since the beginning of this pandemic, and over 360,000 of our fellow Americans have died. I think that sometimes we get numbed by these statistics, and it's useful for us to just think that each and every one of these 360,000 persons is somebody's father, somebody's mother, somebody's wife or husband. These people were all deeply loved and very much missed. Every day today in the United States, we have over 250,000 new cases of COVID-19, and we have over 2,500 deaths per day. This is like having a 9/11 World Trade Center event in our country every single day. And that's why we're here this evening, to talk about that, and now to talk about this really optimistic, hopeful message that finally we have a way that we can start to dig our way out of this pandemic, to get ourselves out of this predicament, and that is the COVID-19 vaccine. And the biggest tragedy that I can think of is that now that we have this useful tool, is if we aren't able to utilize it fully, and we have a large proportion of people who, for whatever reason, have vaccine anxiety or resistance, or don't want to accept the vaccine at this crucial juncture. And that's really why we're here tonight, is to talk about the facts versus the fiction and try to dispel some of those myths and misinformation that may be out there with regard to the vaccine. Again, I'm very pleased to be here. I'm looking forward to the interaction and the questions that will be entertaining.
Thank you, Dr. Rupp. And now we'll go to Dr. Ernest.
Thanks, Doug. First of all, I want to thank Doug and the whole Simulation and Motion team for hosting us here tonight and to put on this production. I also want to thank Dr. Rupp, and I certainly enjoy sharing the stage with him. I want to thank him for taking the time in his busy schedule to come and talk to you guys tonight. As Doug mentioned in the introduction, I serve as the State EMS Medical Director. I also serve in a capacity of Medical Director for a number of agencies, all the way from a large urban agency down into the small rural agencies and kind of everything in between. And working through this pandemic and working alongside many EMS professionals like yourself, realizing that EMS does truly serve on the front line of front lines. Many times patients will present to the medical system through the 911 system or via ambulance before they even reach the hospital doors. And so realizing that you sit on the front lines of treating this very interesting, challenging, complex patient population in a disease that has impacted the entire world, and the statistics bear it out, as Dr. Rupp had mentioned. So with that, I just want to say that EMS, given your exposure and given the fact that you're on the front lines, you're in people's homes, maybe in a less controlled environment, that the exposure is great. Although there may be certain precautions or PPE that you have on, the idea of a accidental or a non-intended exposure is a real thing. And I have seen that with multiple of my agencies where we thought we were going on a certain type of call, had nothing to do with an infectious disease-related complaint, and sure enough that patient had COVID, ended up exposing a large number of personnel from that EMS agency. So the exposure risk is real, and as Dr. Rupp alluded to, the fact that we now have an ability to kind of dig our way out of this pandemic and to be able to protect ourselves on the front line, to be able to care for those patients, especially in smaller communities where resources even pre-pandemic were scarce, to say the least. And with the idea that a single patient could take on an entire EMS squad and put them out of service for upwards of 2 weeks while they recover from their infection, to say that we have this ability to protect ourselves is nothing short of miraculous, and a testament to the true hard work of the researchers and everyone that's worked so hard to develop this vaccine. So with that, I want to thank everyone with Simulation Nebraska, also Dr. Rupp, and look forward to this evening and taking your questions.
Okay, thank you, Dr. Ernest. And thank you to both of our panelists for your insightful comments. Before we begin our question and answer part of our presentation, we will be showing a couple of videos. The videos of two of our frontline workers receiving their COVID-19 vaccinations and some of their thoughts surrounding the vaccinations. Our first interview is with Charles Wilkins. Mr. Wilkins is a non-invasive cardiac tech and paramedic at Nebraska Medicine. Mr. Wilkins is also a critical care flight paramedic with the Nebraska National Guard and a staff sergeant with G Company 2, 104th out of Lincoln. Our second interviewer is Nick Parker. Mr. Parker is a volunteer with the Gretna Fire and Rescue and is a firefighter EMT. We will now hear from Mr. Wilkins and Mr. Parker.
For those of us that work in the hospital, we see the long-term effects. We are working day in and day out, especially in the COVID units, helping people breathe and just thrive. There's a difference between surviving an illness and thriving off of an illness. Sure, it's very survivable, but the long-term effects make thriving off of it more difficult. So I'd say if you want to be part of the solution and not have to worry about long-term effects of the disease, get the vaccine.
All right, quick poke on 3. 1, 2, 3.
Even though we are out in the community and we are exposed to residents within that community as first responders, the last thing I would want to do is expose my family to the hazards that we face on a daily basis. But secondly, it's important for the community to know that we believe in the vaccine and that we as a department are being proactive with our first responders to ensure that we are staying safe within the community as well.
In addition to allowing us to video them receiving their vaccinations, Mr. Wilkins and Mr. Parker reported back to SIM Nebraska for the first 10 days immediately after they received their vaccination. Please watch our Facebook page for the next 10 days for daily reports on how the men felt after their vaccination. We began our question and answer session with a few questions that came in prior to the event. The first question, what are the side effects of the vaccine and are there any long-term effects?
Well, I think it's important that we're very transparent with what are the side effects and the toxicity of the vaccine. Nearly everybody who gets the vaccine is going to have a sore arm. I can personally attest to that. It does tend to go away within the first 1 or 2 days after the vaccine. In addition, what we call the reactogenicity of the vaccine, meaning that after you get the vaccine, your body responds to that, and many people do have some fairly limited, mild to moderate side effects from the vaccination. Up to about 50 to 60% of people will experience, again, some relatively short-lived side effects, such as maybe some fevers, chills, muscle aches, sometimes a bit of headache, some malaise or fatigue. Again, these tend to go away after just a day or two. And when you compare that to the real risk of having serious illness to COVID-19, it sort of pales into insignificance. This is clearly, when you look at the risk-benefit ratio, very much favoring getting the vaccine.
And as far as long-term effects, has there been any studies? I realize it's only been a few months since the vaccine was even tested, so it's really hard to say.
Well, as far as we know, the long-term effect is that you're immune to COVID-19. We really don't have any long-term side effects or toxicity that have been described. There are a few people who have more serious allergic reactions to the vaccine. There have been a small group of folks who have been described that have serious allergic or anaphylactic type of reactions. That's probably the most serious thing that we worry about as we administer this vaccine. We need to do it carefully. People need to be observed for 15 to 30 minutes after the vaccination is given to make sure that they're not developing any of those more serious allergic type reactions. But as far as long-term effects from the vaccine, those haven't been described. Obviously, we've had limited experience over the longitudinal experience with the vaccine. So I can't sit here before this audience and say that we know that after 2 years that X, Y, or Z has or hasn't occurred. But the signals are all very, very favorable right now, that we're not seeing serious adverse events. We're certainly not seeing anything that's lingering or permanent as compared to disease due to COVID-19, which can cause permanent disability, very serious illness, and even death.
Okay, thank you. Dr. Ernest, any other comments you wanted to make there?
No, I think Dr. Rupp summed that up quite nicely. And again, despite not knowing the long-term effects, as we've seen both in the study phase and then also people getting it, that it seems to be relatively safe and only concerned about those with anaphylaxis. So highly encouraged to get the vaccine.
Okay, thank you. Next question is, should we be concerned that this was developed in under 12 months?
Well, it was developed extremely quickly. And I think that just shows the accomplishments that can be achieved when we have the full force of the government and resources, along with the innovation and the research and the lab capabilities, as well as the full might of industry throughout the world. This really shows that when we mobilize the medical research industrial complex, that we can achieve some great things. So the fact that this vaccine was developed quite quickly, I don't think should be of real concern to folks. I would be reassuring to people that despite going at a very quick pace, they did not cut corners with the safety evaluation of this vaccine. So the studies have been done, large phase 3 trials of the 2 mRNA vaccines that are currently being used in the United States. Each one of those trials was tens of thousands of patients in each group, placebo controlled as well as the vaccination group. These were blinded studies, controlled studies, very, very rigorously done. And it was very reassuring to me, actually, that during the conduct of these trials, on occasion, they were paused for moments while they examined potential adverse events. They did not rush this forward. The FDA did, I think, a very, very good and transparent job in looking at all the data and then coming to, I think, a very reasonable decision that they be granted emergency use authorization. Now, please understand that this is not full authorization. This is not a full approval by the FDA because, again, we don't have years of experience with the vaccine, but all the signals are very good, very reassuring that it works and that it's safe. And again, when you look at the risk-benefit ratio, it's very clearly siding on getting the vaccine.
Okay, thank you. And we had a question about, was aborted fetal tissue used in the development of the vaccine?
Yeah, this is an important point for a lot of people. And I would be very reassuring to just relate that there is no fetal tissue used in the manufacture of this vaccine. So there are no fetal cells in the preparation. There are no fetal cells that are used in the manufacture of the vaccine. Multiple religious authorities and regulatory bodies have come forward with saying that they fully support use of this vaccine in humans.
Okay, thank you. And we had a person contact us saying that they're currently pregnant and they were curious as to whether or not they should get the vaccine.
Yeah, this is another great question. And again, we don't have experience with specifically with pregnant women getting vaccinated. What should be pointed out is that there's no reason to really think that this vaccine will be detrimental to pregnant women. And so studies have been done in various animal models, the development and reproductive toxicity models. We've not seen any kind of signal that this is detrimental to a developing fetus. But clearly, it's not been studied in pregnant women. Now, the regulatory bodies and the authoritative bodies, the American College of Obstetrics and Gynecology, as well as the Maternal Fetal Medical Society, have both come forward with strong statements to say that pregnant women should not be excluded from vaccination, that it should be made available to them, but that this is a decision that a woman needs to make in concert with her providers to decide what's in the best interest of that particular person. Now, we do know that COVID-19 can be more serious in pregnant women, that they're more likely to get a more serious illness, to end up in the hospital, that it may be associated with adverse events for the developing fetus, so premature birth, those sorts of toxicities can be seen due to the infection with the virus. So we know that there's a risk from getting sick with the virus. We have a potential benefit from getting vaccinated. And so again, the bodies that are most involved with taking care of pregnant women have come forward to say that there isn't really a reason to be excluded, but this is a decision that isn't made on a bunch of data, so we can't reassure people that this is completely safe for pregnant women. But our hunch is at this point that it would be a safe vaccine. And it should be also pointed out that many vaccines are safe in pregnancy. So for instance, influenza vaccination, Tdap for tetanus and pertussis. These are vaccines that are very, very clearly indicated and very much recommended for pregnant women. So it wouldn't be out of keeping to have another vaccine that would be recommended in pregnancy. But we just don't have the track record and data to be able to say that, yes, this is perfectly safe for pregnant women.
Okay, thank you. And as a follow-up question, is there any impact on the milk production for breastfeeding mothers?
Again, has not been studied extensively in breastfeeding women. There's no indication that this would be detrimental to milk production, or if there was any of the spike protein that was in the milk, that this would be detrimental to a newborn infant. So the body of evidence and the opinion is that vaccination can be done safely in breastfeeding women and is not a problem. One other thing in the previous question that I would point out is that there actually was a small group of women, even though pregnant women were excluded from being involved in the vaccine trials, there were small numbers of women who became pregnant shortly after receiving the vaccine. Those women are obviously being watched very, very closely. There's no indication to date that there's a detrimental effect on the pregnancy, but obviously those pregnancies have not come to term.
Okay, thank you. We have one of our registered folks that sent in an early question saying that they've already had the had COVID-19. Should they still get the vaccine?
Yeah, the recommendation is that they go ahead and get the vaccine. The reason for that is that people who have had more mild COVID-19 may actually have less of a robust antibody response, and therefore their natural immunity may wane relatively quickly. We do have a few sporadic reports of people getting a second infection with COVID-19 within about 3 to 4 months of the first infection. So it's really not known how protective a prior infection with COVID-19 is. So the recommendation is that folks go ahead and get the vaccination if it's made available to them, even though that they've had COVID-19 in the past. We do think that having a natural infection is fairly protective for at least about 3 months. So if people wanted to postpone their vaccination for up to 90 days, that would be acceptable. But again, don't miss your opportunity to get vaccinated by postponing. Go ahead and go forward with the vaccine. Clearly, we don't want to vaccinate persons who are in the midst of an active COVID-19 infection. So you need to be recovered. You need to be back to being healthy, and then you can go ahead and get the vaccine.
Okay. All right. Are there any populations that should not get the vaccine?
Yeah, there are, and we've kind of touched on that just very, very briefly in some of the introductory statements, and that is probably folks who have a known serious allergic reaction to the COVID-19 vaccine or components of the vaccine. And about the only thing that's in the vaccine that can trigger an allergic reaction is a substance called polyethylene glycol. This is actually a component of some laxatives. So some of the over-the-counter laxatives, some of the bowel preps before colonoscopy contain this chemical. So if you have a serious allergic reaction to the vaccine or to the vaccine components, you probably need to step back and not receive the vaccine. Now, people who have allergic reactions to food, peanuts, eggs, insect stings, those sorts of things, they can go ahead and go forward and get the vaccine. People who have very mild reactions can be watched fairly closely after vaccination, and we do have the capability of reversing some of these mild reactions with Benadryl or other counteractive medications. So again, we need to be careful with the vaccine. We need to be aware that there are some serious allergic reactions, but for the vast majority of people, they should go forward with confidence that they can get this vaccine.
Okay, thank you. We had a person that contacted us and said they have several coworkers that are anxious about the vaccine and are thinking about not getting it. What should that person tell their coworkers? Dr. Ernest, you want to start with that?
Sure. Yeah. So, and I've actually seen this quite a bit in the field and working with the EMS agencies that, and kind of within the fire EMS culture, you hear one thing and it kind of spreads literally like proverbial wildfire. But that being said, to the comments that Dr. Rupp has already made tonight, that the vaccine is something that is safe, that it is indicated, and as we previously mentioned, given your risk as a frontline healthcare worker, that it would still be highly recommended. And that's kind of what the point of this talk was here tonight, was to try to dispel some of those fears, maybe some of the misconceptions that are out there, to give you the most factual information so that you can make an informed decision.
Yeah, and I think unfortunately, this is a symptom of a bigger problem, and that is that, there is a deep mistrust in certain segments of the population around medicine and around science, around authority. And some of that mistrust, unfortunately, has been well earned. There are some, examples of how medical science has not been transparent and fair and equitable for certain populations within our country, and that needs to stop. Clearly, this needs to be where we bring transparency and good information to people and help them make well-informed decisions. Again, I think that there's a lack of ability sometimes for people to do good risk-benefit analysis. And when folks pull back and look at this intellectually and intelligently and realize the real downside of having COVID-19 as an illness. And we've already talked about that. Yes, one of our interviewers early in the program pointed out that yes, this is a survivable illness for the vast majority of people. And most of the folks who are out there working on the squads and in the EMS and in the emergency departments are generally young, healthy people. They're probably not going to die from this. But having said that, there are young, healthy people that do die from this. And in addition, there's an awful lot of folks who have some of the lingering effects from COVID-19. I only wish that you were on my email list and receiving the calls that I get every day from folks who are saying, I got this and I'm still not back to normal. I'm tired, I'm fatigued, I have low-grade fevers, I'm achy, I can't get back to taking care of my kids or doing my job. And those things, unfortunately, can linger for months. So this is not a disease that you want. If we can prevent it with a safe and effective vaccine, that's your best bet and that's your best decision.
And I would add one other thing to what Dr. Rupp said in terms of the lingering effects. And I have had personal acquaintances professionally and personally that have mentioned these lingering effects, and especially within the fire and EMS service where it is such a physically demanding job. We have had people that have had an extreme difficulty and have gone on to light duty because they cannot meet the physical demands and rigors of the firefighting service. So again, this is not something that you want. If we can avoid this, that would be all the better. So.
Okay, thank you. If a person's only considered to be immune for 90 days after they have had the virus, how long is the vaccine good for?
Well, we don't have a full answer to that. We don't know how long the protective effect for the vaccine is. Again, the initial data is a home run. It's amazing. When this vaccines were being developed, I thought that if we had a vaccine that would be 50 or 60% efficacious, that would be good enough to really get out and into the community. These two emergency use authorization vaccines, the Moderna vaccine and the Pfizer vaccine, both mRNA vaccines, are 95% efficacious in preventing clinical illness due to COVID-19. Now, we don't know everything about this, clearly. We don't know whether it prevents completely asymptomatic acquisition of the virus and then shedding of the virus, and I suspect we'll have some questions about that yet to come. We don't know how long the protective effect from the vaccine is, but initially, up through the first, we really now have about 4 months of data that's been published. The protective levels of antibody are excellent. They don't seem to be diminishing even out at the 3 to 4 months of experience that have been published. We think that we can actually do a better job than Mother Nature with the vaccine. And so the vaccine triggers both a humoral immune response, meaning that you create antibodies, but it also interacts with other cells within the immunologic system to give you long-lasting memory. That's what we're hoping for, and that's what the data suggests at this point. We truly won't know this until we're out, years, but right now the signals are all very, very good, very much favoring that we're going to have a long-lasting immunologic effect from the vaccination.
Once a person's had the vaccine, when can they stop wearing a mask?
Well, I'm hopeful that over the next several months, as we gather more information on the full effect of the vaccine, we're going to be able to make a more intelligent decision in that regard. Now, right now, as I just said, we aren't real clear whether the vaccine, after getting 2 doses, will prevent people from asymptomatically acquiring the vaccine and then perhaps acquiring the virus and perhaps shedding some of the virus. We do know that it prevents clinical illness, and it seems to be very, very effective in doing that. But it's still possible that a person who could get vaccinated could acquire and shed the virus without becoming ill. So for that reason, the recommendation is that we go ahead and we continue to wear masks for at least the near-term future. Now, what I would relate to the audience is that there is some information to suggest that the vaccine does really decrease the asymptomatic shedding of the virus. And so in the Moderna studies, they actually swabbed people's noses as they came back in for their second shot at 4 weeks. And they found that there was about a 2/3 decrease in the number of people where they were able to detect virus in the nasal swabs compared to the placebo group of persons. So that would, I think favorably indicate that we do have an effect against asymptomatic shedding. It's maybe even stronger after the second dose, and only time's going to tell as more and more studies are being done to look at exactly that question. So I remain guardedly optimistic that when we get enough people vaccinated and we have herd immunity within the community, that we're going to be able to stop wearing masks. But for right now, we're telling people that they should continue to wear their masks, do their distancing, do their quarantine if they're exposed, all those things until we really understand the full beneficial effects of the vaccine.
Okay. I get my flu shot every year, have for years and years, and I go in and I get a single shot. With this particular vaccine, though, we need to go in for 2 different doses. Why the need for 2 doses in this particular vaccine?
Well, we think that the first dose serves as kind of a priming mechanism, and then the second dose serves as the real booster that will give people long-lasting immunity. There is, again, some data that with the first shot, that if you look at the publications, you'll see that within about 10 to 14 days of receiving the first dose, the curves really flatten out for the people who've received that first dose. And then as they get their second dose, that curve continues to be essentially flatline, showing the effectiveness of the vaccine. They've not been studied with just 1 dose, and so we really don't know the full effect of just having 1 dose. Right now, your best bet is to get vaccinated and do it like we've done in the studies, that we do know that that's an effective regimen. So right now, the recommendation is that we go ahead and we give the 2 doses, serving as a priming and a boosting dose, hopefully giving long-lasting immunity. And quite frankly, this is fairly consistent with many other vaccines. So for instance, your MMR, your measles, mumps, rubella vaccine, as children, you're given 2 doses. You're given a booster dose for tetanus when we know that immunity has waned. Every year we have to get a different flu vaccine because the virus mutates a little bit and we have to adjust for that. So there are plenty of examples of where people do need more than 1 injection to get the full benefit from the vaccine.
Okay, thank you. We're going to go ahead and start taking some questions that have come in the chat, and the information I'm being fed here shows that we have quite a few questions in the queue. So
good, that's great.
Got some coming your way. So, is there any information yet on will this particular vaccine work on the variants that we're now seeing in the U.S. and elsewhere in the world?
Yeah, so I think what the questioner is referring to is this variant called a B.1.1.7 variant that was first really seen in the UK and now is being described in at least 40 other countries. So it's probably in this country, we know that it's in several states, 5 or 6 states that it's been described. It's probably in multiple other states. Now, this variant seems to allow perhaps greater spread, contagiousness of the virus. It's not fully known why that is, but the thought is that this mutation allows the virus to more avidly adhere to human epithelial cells. Now, there isn't any indication that the infection is more serious, so the mortality rate and the rate of serious illness is not greater than the baseline rate. And there's no indication that the virus has evaded immunity from the vaccine. So that's the really good news. That is very, very reassuring. We don't think that this virus has evaded the ability to gain immunity to it from the vaccination.
Okay, thank you. A little bit of a clarification on the question earlier about the breastfeeding question. In regard to breastfeeding mother, could the vaccine cause a depletion in her supply, and will it cross over from her milk into the baby?
Yeah, so I'm not aware of any information to suggest that there are ill effects of vaccination on breast milk production. Clearly, breastfeeding and pregnant women were excluded from the studies, so we don't have a large database. But again, the recommendations from the authoritative bodies suggest that this is a safe vaccine for breastfeeding women and that you should not delay vaccination for that reason. If a small amount of spike protein would be excreted into the breast milk, there's no thought that that would be detrimental to a newborn infant. So again, most folks are recommending to their breastfeeding patients that they go ahead and get the vaccine. But again, I'll be fully transparent and fully state that we don't have a lot of experience with breastfeeding women. That's one of the areas that needs to be studied more fully.
Okay, thank you. If an EMS unit or in a hospital emergency room is taking care of a person that's had a reaction to the vaccine, what kind of treatment do you think we should be able to give them? And there's not anything really specific about what the reaction is, so it's kind of a broad question there.
Yeah, I think maybe on that one,
Sure.
Dr. Ernest,
Sure.
I'll defer to you.
So clinically, at least in our emergency department, we haven't seen any adverse effects directly present to the ED for treatment. As Dr. Rupp mentioned, in the very rare case that someone would have an anaphylactic reaction to one of the components of the vaccine, it would be a standard treatment course of steroids, possibly epinephrine if it were truly an anaphylactic shock type of reaction, and then basically conservative treatment. There'd be no specific treatment outside of a normal allergic reaction treatment algorithm. Otherwise, if it were just from the side effects of the vaccine, which Dr. Rupp had already mentioned, usually, again, that's just conservative treatment of fluids, maybe ibuprofen or Tylenol, and rest, and most of those symptoms will go away within the first couple days.
Okay, thank you. Could people with special situations, such as low kidney function, and we've talked about pregnancy, or immunosuppressed or cancer patients get the vaccine?
So these are also areas where we don't have a full database to be able to make fully informed recommendations on the efficacy of the vaccine in those groups. The thought is that in most immunosuppressed patients, that the real unknown question is whether they'll respond to the vaccine and gain the benefit from it. There's no reason to think that they're going to have additional adverse events from the vaccine to the best of our knowledge. So most groups that I'm aware of formulating these recommendations are suggesting that the patients with various forms of immunosuppression, whether that be due to medications or underlying immunosuppressive disorders, go ahead and get the vaccine when it's made available to them. We just really don't know how effective it will be. And so that's one of the things that's going to be studied very carefully in groups of patients who are immunosuppressed to ascertain how effective it is in those patients.
Okay, thank you. And I think you've answered this a little bit, but just to confirm, do you really have any idea how often you think a person might need to be vaccinated once they've had the 2 doses?
Yeah, we really just don't know,
Okay.
Doug. I think that that's one of the biggest questions that's out there right now. I just saw today in the New England Journal information being offered with regard to the antibody levels out at 4 months of experience, and again, they're very, very steady, very, very reassuring that there's a longer lasting immunity. We just don't know if this is going to peter out at 9 months or 12 months or 2 years. It's really unknown.
Okay. In one of the questions coming in says, is it true that you shouldn't treat the side effects of the vaccine? In other words, don't take Tylenol if you have a fever, something like that after the vaccine's been administered.
Well, I guess there are some considerations of whether trying to blunt these reactions to the vaccine might also blunt some of the effective immunologic response. For the most part, I think that if you're developing symptoms that are troublesome, particularly fevers, chills, headaches, muscle aches, it's very, very reasonable to take some Tylenol around those side effects and blunt those in order to get through those first day or two after the vaccine. Obviously, if it's a more mild type of reaction and you're able to put up with it and soldier on and make your way through your day, that's certainly probably a better way to cope.
Okay, thank you. It's a little bit off topic, but if a person gets COVID for the second time, could their symptoms be worse than the first time they got it?
We have so limited number of persons who have had COVID-19 for a second time that I really just don't have the information to answer that question with really any degree of certainty. I'm not aware of any information to suggest that the second infection is more severe.
Okay. I know there's been some very limited documentation that there's been a person who got the first dose, ended up with COVID-19 right after the first dose was administered. Would that person be eligible for the convalescent plasma treatment?
So if you've had a first dose of the vaccine and then you're unlucky and you were exposed, around the time that you were getting the vaccine or before that, and then you develop clinical illness due to COVID-19, the recommendations are that you go ahead and treat that person with acute infection with whatever modalities you think are most beneficial for them. So in other words, you wouldn't hold off giving a antiviral medication or the monoclonal antibody preparations that are available now for a high-risk person, thinking that they'd been vaccinated. So we're really not using the vaccine as post-exposure prophylaxis or as a treatment modality. So if you're sick, you're having symptoms, if you are in a higher risk group and you've received one dose but then you develop infection, we would recommend go ahead and treating you like you hadn't had the vaccine, essentially.
Okay. With a large number of cases and the belief that most of the population's already had the virus, why do we not already have herd immunity?
Well, most people have not had this infection. And so most of the data would suggest that in most parts of the country, 10, 15, 20% of people may have been infected. Again, the longevity of natural immunity appears to be fairly limited. And so it makes great sense to continue to push forward with our vaccination program. The number of people who need to have immunity to fully reach herd immunity, and so that may be a term that not everybody's familiar with, but herd immunity is when you have enough people in a population that are immune to the disease that it no longer can find susceptible persons within the population and stop circulating. So the whole name of the game is getting to herd immunity. The best way of doing that is through vaccination. I've seen low estimates of herd immunity being achieved at maybe 40 to 50%. Most experts are suggesting that it needs to be 70, 80, 85% of the population being immune before we'll really see this virus getting tamped down. So we've got a ways to go yet, and the best way to get to herd immunity is through vaccination, not through natural infection. I'm always chagrined when I hear people say, what doesn't kill me makes me stronger. What doesn't kill you might leave you permanently disabled as well. And that's a real unfortunate thing that we've got people who, are of this misperception that, they should just let nature take its course and get to herd immunity through natural infection. That's a really, really, I think, foolish and rash way to try to go forward. And the best way to get to herd immunity is with the vaccination. That's by far the safest way to get to where we need to go. This is the way we get ourselves out of this hole that we're in. This is the way we work ourselves out of this predicament and get ourselves back to some degree of normalcy that we all really, really strive for and hope for.
Is there any truth to the rumor that a small number of people have developed Bell's palsy after they've received their immunization or vaccination?
Yeah, so this is more than a rumor. So within the studies, there were a small number of people who developed Bell's palsy after being in the study. They are more heavily weighted towards the people who received the vaccine. But what folks need to understand is that these were very large studies with tens of thousands of persons in them. And so it's just natural that all the things that happen, normally are going to continue to happen after you've received the vaccine. So people continued to have heart attacks. They continued to have strokes. They continued to die from other causes. And some people did develop Bell's palsy. Now, when they've looked at these very carefully, the amount of Bell's palsy that they saw within the vaccine recipients did not rise to a level that was beyond what would just be expected in the normal population. So this is one of those things that's going to need to be watched very carefully. And please understand that already in the United States, we have now vaccinated millions of people. And so if there is any signal for Bell's palsy, that's going to be really looked at carefully, and we'll pick it up very, very quickly. But to date, the information is reassuring that the rate of Bell's palsy in vaccine recipients is not higher than what we just see out in the normal population.
Okay, thank you.
Doug, if I could follow up with just one other comment
Sure.
that I sometimes hear, and that is concern about vaccination in association with Guillain-Barre Syndrome. And I don't know if that question has come in, but oftentimes it follows right on the heels of Bell's palsy, because it is, again, another neurologic complication that has in the past been, in very rare instances, associated with vaccine. And so some people might remember back during the swine flu scare back in 1976, there was a true association between flu vaccination and Guillain-Barre syndrome. Since that time, we've not really seen that association, and there are no reports of Guillain-Barre following the COVID-19 vaccination. Again, there will be some sporadic cases because this is something that just occurs naturally, but we're not seeing any signals right now that Guillain-Barre is associated with the COVID-19 vaccination.
Okay. If someone has a history of anaphylaxis and they get the vaccine and they have a reaction to the first injection, what should they do? Should they go ahead and go with the second dose, or is there a possibility that they had a mild reaction to the first dose and the second dose may even be more reactive for them and cause them even more problem?
If somebody has had a serious anaphylactic reaction to the vaccine, this would be a contraindication to receiving the second dose. So if people have truly had an anaphylactic type reaction, difficulty breathing, clearly urticarial reaction, something triggering a very strong signal that they've had a serious allergic reaction, then they should not get the second dose of the vaccine. Now, unfortunately, there's a lot of overlap sometimes between people who develop anxiety or maybe a vagal reaction due to the administration of the vaccine. Sometimes it's a little bit hard to discern the difference between an allergy and a vagal reaction. There are sometimes some subtle differences that clinicians can look for. Clearly, those types of people who get the vaccine and then they might feel a little flushed, feel a little pallor, get a little sweaty. Even sometimes they can faint from a vagal reaction. Those would not be a contraindication to getting the second dose. Now, obviously, we have to be very careful around that second dose, watch folks closely, be prepared to reverse a reaction. But for the most part, those types of mild reactions or vagal reactions, they can go ahead and safely get that second dose. And I don't know, Dr. Ernest, maybe you want to comment on that as well, because sometimes there is a little bit of an overlap. And
Sure.
I know you as an emergency department doctor are sometimes trying to figure that one out.
Yeah, exactly. And some some of that can be a little bit difficult to parse out. But again, there are some distinct signs and symptoms of an anaphylactic reaction versus someone who maybe has a fear of needles or does get a little bit of that warm flush feeling or has a vagal reaction. There are some distinct differences that obviously those will be treated slightly differently. And again, the non-anaphylactic reaction, again, would not be a contraindication for second dose.
Okay, thank you both. There's been some folks that have been talking about the fact that they've had some of that sore arm and things like that you talked about from the first dose, but then with the second dose, it's even worse. And is there any correlation between Pfizer and Moderna, as far as which one might give you a little more problem?
Yeah, so that is a correct observation, that these reactions that people are experiencing tend to be worse if you're younger, and they tend to be worse with the second dose of the vaccine. And that is just a fact of the matter. Again, most of them are mild to moderate. They resolve within 2 or 3 days. And, again, I think they're a small price to pay to knowing that you're protected, that you're not going to get serious illness, that you're not going to get sick and bring it home to your family. Again, I think the risk benefit is clearly on the side of getting the vaccine.
Are there any concerns with people that have a shellfish allergy as far as receiving the vaccine?
No, there are no contraindications for people who've had food allergies, eggs, shellfish, peanuts, those sorts of things, insect bites. Those people can go ahead and get in line for the vaccination.
Okay, and we've got a question here. We're going to step a little off topic again, but I think it's something that's pretty valid for us to talk about. Can you talk a little bit more about the remdesivir? And the second one's even harder for me, the bamlanivimab. I'm going to let you say that one. I have no idea.
Sure. So remdesivir is a antiviral preparation that has direct activity against the virus, prevents it from replicating. And so that is used in people who are acutely ill, who are in the hospital, generally reserved for folks who are showing evidence of lower respiratory tract infection and hypoxia. The other medications that you're referring to are the monoclonal antibodies that are directed against the spike protein. So there's two of these that are available on the market, made by two different companies. These are indicated for people who have developed illness, but they're early in their phase of illness. They're not hospitalized. They're not needing oxygen. And it's being directed towards people who are at a high risk of progression of disease. And so people who are older, who have other predisposing conditions, should go ahead and get that preparation to prevent them from getting sicker. Now, these same preparations have been studied in sick people in the hospital and haven't been really shown to be of much benefit. So the time to give those is before you get very sick. The remdesivir and the dexamethasone and baricitinib, those are reserved for patients who are sick in the hospital needing oxygen, and that's where those have been shown to be beneficial. So we really have come a long, long ways in a year when you think about it. You know, this time last year, we were just seeing those first reports coming out of China. We were all very worried that we were going to be experiencing this pandemic, which unfortunately has come to fruition. But when you think about the fact that we now know so much about this disease, that we have therapeutic agents both to prevent progression of disease as well as treating sick people in the hospital, preventing them from dying. When you think about the fact that we've got a vaccine, two of them now, that have come to market, and multiple other types of vaccines that are knocking on the door, this is really pretty amazing what we've been able to accomplish in this past year. And I would give people, that picture of optimism, that we're developing new agents to treat, we're developing agents to prevent, we're getting smarter about how to take care of people. We really have come a long, long ways in this.
Okay. Should someone who has had ITP and a splenectomy to correct the ITP get the vaccine?
Yeah, so we don't know how well the vaccine works in splenectomized patients. So that's the real question is, will you get the full beneficial effect from it? There is no information to suggest that this is going to be detrimental.
Okay.
And Doug, I don't know if the audience would like to get into a little bit more about the different types of vaccines that are coming along. It might be useful for folks to know a little bit more about that.
That's a question that hasn't been asked yet, but that's a question that I have, so I would really appreciate that.
Yeah, so sure. These first two vaccines that have come to market are called mRNA vaccines, messenger RNA vaccines. And they are really a breakthrough for us. Even though we've been studying this technology for decades, this is the first application of this technology for a vaccine. And so what it does is it delivers the message for making a protein to your cells. And then your cells make that protein, in this case, the spike protein, and your body sees that as foreign and makes a reaction, an immunologic reaction to it that then protects you from an infection. There are other vaccines that are being developed that use an attenuated or weakened, harmless virus to deliver that protein, that spike protein, to your body, and therefore you see it and you develop immunity. And then there are more traditional approaches towards vaccination in which they're just simply using the protein itself, often with an adjuvant, so that your body can see the protein and make antibodies towards it. So those are really the three different approaches. In some countries, they're actually using weakened coronavirus or killed coronavirus as the vaccine. Those are not being studied in the United States. I don't anticipate that those will be used when we have what I think are these other probably safer ways of going forward. So none of these are live virus vaccines that are currently being used, the mRNA, and that's oftentimes the concern for immunosuppressed patients, and we've already talked about some of those questions. And then I would just like to equate, the reason for vaccination and sort of try to give people an analogy for it. So, your immune system kind of serves as a guard. So let's say you're at home and you've posted a guard at your front door to keep out intruders. That's your immune system, that guard. And for the most part, it's awake and it's alert, and it detects the intruder. But the guard doesn't have a loaded sidearm, and they haven't had target practice. And so when you immunize somebody, what you're doing is you're giving your guard a loaded weapon and you're training them to detect the intruder and have target practice. So now they're all primed and they're ready to keep out the intruder. Now, when you're immunosuppressed, what happens is your guard is kind of asleep at the job, and they allow the intruder to come in and to ransack your house. And so really that's what we're trying to do by giving these people the vaccine, is we're just trying to train their guard, give them a weapon that they can use, and treat them and train them how to use the weapon most effectively. That's, I think, a good way to think about this.
And Doug, or Dr. Rupp, if you wouldn't mind mentioning, the one concern that I've heard from a number of people is with the mRNA vaccine, that somehow will impact or alter someone's DNA or genome and get into the nucleus of the cell. If you can maybe just speak to that.
Yeah, that just isn't going to happen. The RNA doesn't get into the nucleus where people's DNA resides, and so it's not going to have the chance to inculcate itself into your genome. In addition, it just really doesn't have any of the machinery that would be necessary to do that. So it doesn't come with the replication that it would need. It doesn't come with the integrase, which is an enzyme that allows it to get into the DNA. So there's really very, very reassuring information and very, very little concern that the RNA is somehow going to alter your genomic message or genomic material.
Okay, thank you. Gentlemen, we are about 3 or 4 minutes away from being at the hour. We have about 5 questions left. If it's all right with you, I'd like to go ahead and try and get through those questions.
We'll do some speed dating. Go.
We'll be all right. There you go. All right. This one's actually for you, Dr. Ernest. So
yep.
you need to go to work here.
All right.
In our area, we've had a lot of negative reactions to the antibody infusion. Is that something that you've been seeing in the ED at all?
And maybe as a clarifying question, there reactions like someone doesn't want to get that, or that they've actually had a physical reaction.
They've had the antibody treatment and then they had a reaction afterwards.
Sure. And whether or not they're coming to the
Are you seeing that in the ED at all?
I have not seen or really heard of any of those types of cases. We're an ER that sees north of 60,000 patients a year. And to my knowledge over this past year, and we are a center that uses antibody therapy. I am not aware, unless Dr. Rupp, you're aware, I have not seen anyone present to the emergency department post-infusion of antibodies.
You can see some allergic reactions to these monoclonal infusions, and that's true with any of the monoclonal antibody infusions that people use for a variety of diseases. We've not seen any longer-lasting side effects or toxicity that I'm aware of. There are some anecdotal and sporadic reports that no doubt will be gathered as we gain more experience.
Okay, is there any truth that the vaccine causes infertility in women?
No, that's simple. No, doesn't do it. There's some, hypothesis that reaction to the spike protein will cross-react with a protein found in the placenta. That's been debunked. Most people think that that's just totally bogus and bunk.
Okay. If the second dose is given, would you recommend?
Can I come back to that?
Nope,
I'm
sure,
sorry,
go ahead.
because
Nope, that's fine.
because people have expressed that in the past, and just think that if that's true, then getting sick from the coronavirus would have the same effect.
Okay.
And we've really just not seen this coronavirus infection causing infertility amongst women. So I think that's just, again, a total bunch of bunk.
Okay, thank you. As far as getting the second dose, if I get the first dose in my right arm, should I go on my left arm? Does it make a difference?
I think it's just personal preference.
Okay. Is there any information with Ivermectin in the prevention of COVID?
Yeah, so Ivermectin is a medicine that we've had for a long time period. treating parasitic, that's what I was trying to remember, an anti-parasitic drug. There's some test tube information suggests that it might have activity. I think this is kind of like the hydroxychloroquine story, where there's some test tube information, maybe a little bit of over-enthusiasm. I'm not aware of any really good body of data to suggest that this works. I don't recommend it.
Okay, thank you for your speed dating. We have one final question, and then we'll go to some closing remarks by both of you. What are your thoughts on the use of Azithromycin as a preventative drug?
Bad idea. This is an antibiotic, doesn't have any antiviral activity. I just think that the adverse events that we know that azithromycin has on cardiac conduction, other side effects such as nausea, vomiting, etc., far outweigh any potential benefit. I do not recommend use of azithromycin for prevention.
Okay. Thank you. That's the last question we have in the chat for right now. And I would encourage our viewers to go ahead and over the next few minutes, if you have other questions that come up, please go ahead and put them into the chat. And we will go ahead and answer those over the next week on our website and also on our Facebook page. So as in past events, any questions, as I just said, we're going to be on our Facebook page and website next week. And I'd like to take a moment for some final thoughts from our panelists. And Dr. Ernest, I'm going to toss it to you first.
Sure. Well, again, I want to thank the Simulation in Motion program, as well as Dr. Rupp for joining us tonight. And I want to thank you, our audience, for tuning in tonight. I know you guys all have busy schedules and families with the new year and everything, but to take the time to learn more about this, to receive education about this, is truly a testament to you and your curiosity and wanting to better yourself as a provider. So thank you for joining us tonight. The one comment I meant to make in my opening statement that I would want to mention now is that EMS was originally categorized as a 1B in terms of its priority level when it comes to vaccination. And there was a lot of hard work that was done through several agencies throughout the state, Department of Health and Human Services, IAFF, as well as some others that really pushed the state to move that to a 1A category, given the fact that people realize that you are truly first responders on that front line in high-risk situations for exposure. So I would like to just kind of echo to the audience tonight to take advantage of all that hard work to go and get yourself vaccinated and do what's best not only for you as a provider, but also for your squad, your fire department, as well as your community. So thank you again, Doug.
Okay, and just on a personal note, as a retired firefighter and paramedic and police officer, I would like to thank you and everyone else who went that extra mile, and also as a parent of 3 first responders. I appreciate the fact that they have the opportunity to be vaccinated due to the hard work that a lot of people went to get them to where they could get the vaccine. So thank you again. Okay, and Dr. Rupp.
I know we've just got a few seconds, so I'll be quite brief. And again, I would echo the comments that Dr. Ernst related. And, again, relate my thanks for people tuning in and for all the folks who are working to put on this program. What I would relate to the EMT audience is that you guys as first responders are seen as heroes. You are seen as role models. You're incredibly admired. And so you can serve as a real example. You can serve as a role model for folks as you make this decision to accept vaccination and help us stamp out this pandemic. So I urge you to make that decision, to receive the vaccine, and to help us dispel some of these myths and some of the misinformation that's out there. And by receiving the vaccine, I know that your neighbors and your friends will see that, and they'll likewise want to receive the vaccine as well. So please, serve as a role model, get the vaccine to protect yourself and to protect your family and to protect the community. Thank you very much.
Okay. Well, thank you both for your time, for your insight, and your dedication to assisting our frontline care providers with your valuable information. An event such as this could not happen without the help of many people. For fear of forgetting someone, and rather than listing everyone or every organization individually, I would like to just say thank you to everyone who helped make this event possible. And finally, as always, be safe, be healthy, wear your mask, and wash your hands. Good night.